Hi, good evening, everybody, and welcome to this Royal College of Surgeons of England webinar entitled How to Succeed in Core Surgical Training. I'm really pleased to be here. My name is Esther McClarty. I'm the Head of Peninsula Postgraduate School of Surgery for Health Education in England and Chair of the National Body of Heads of Schools, known as COPS. I'm also an invited member of the College Council in England. I have some expertise in surgical training, but joining me this evening, I have Ian Maheshwaran, who's the TPD for core surgical training in Kent, Surrey and Sussex, and Katie Emsley, a successful graduate of the Peninsula Core Surgical Training Programme who's just started her ST3 programme in general surgery in Scotland, and I'll leave her to tell you a bit more about that. And I'm particularly grateful for her because she's on nights at the moment for coming and joining us this evening. Firstly, what I would like to say to you is congratulations, well done. You're just starting your core surgical training at a really interesting time in medicine and surgical training where things are changing fast. Some of you will still be affected by COVID in your hospitals, and some of you will be full on, hopefully enjoying your training. You're a couple of weeks in now, and I'm very hopeful that you've found who your educational supervisors are, you're aware of who your training program directors are, and for those who have college tutors in their hospitals, you're aware of who is your local representative of the TPD to help you get on with your core surgical training. I really hope you enjoy this evening. I really hope you enjoy your core surgical training. But the experts who are going to tell us about the nuts and bolts of all of this are sitting next to me. And so I'd like to ask Ian to start from the TPD's perspective of how to get on in core surgical training.
Thank you, Esther. And thank you for the introduction. So my name is Ian Maheshwaran. I'm a TPD in Kent, Surrey, Sussex. I'm also a consultant upper GI surgeon. I'm also the clinical lead for CRISP. So those are kind of my declarations of interest. As Mr. McClarty said, congratulations. You know, you've made it into core surgical training. You are the creme de la creme. You are the future of surgery. And surgery is going through exciting times. You know, we're doing more with robots. We're doing more computer assisted. We're learning through virtual platforms. And this is the start of your formalized surgical training. So really well done, and I hope that you enjoy the next 2 years. It is 2 years as a program, but I put 18 months in brackets because that's when the ST3 applications are going to open. So you need to focus things a bit more to make sure that you are in a position to apply for those ST3 applications in 18 months. And it is a short and focused, concentrated time of training in core training. And I've put some bottles there, and it's not because I think you should go away and start drinking based on that, but it's about bottlenecks, in that you've come through one bottleneck from either foundation into core, but you're going to go into another bottleneck into higher surgical training if that's what you plan to do. And the narrowness of that bottleneck is going to be dependent on the specialty that you want to go into and the region that you want to go into. And therefore you need to be thinking early about how you're going to get yourself in the best position to be competitive for those higher surgical training numbers. Next slide, please. So core training is really about the development of surgical skills. It's about the development of your core competencies. It's getting you to pass the MRCS or the DONS exam so that you can progress into ST3, hopefully seamlessly. Next slide, please. So I hope most of you will have logged on to the ISCP. As you know, there is a new curriculum that's come in, and I hope that most of you will be up to speed with that. There are some excellent webinars on the RCS website describing the new curriculum updates and changes by John Lund and Keith Jones. So I'd highly recommend that you do watch those. There are other webinars out there as well that describe the new curriculum changes, but what you have to understand is that ISCP is going to become your best friend over the next, hopefully 8 years, because you'll go into higher surgical training and it'll still be there. So it's going to be your best website. It's no longer going to be Amazon.com. It's going to be ISCP, because you need to engage with ISCP from a very early stage, and don't shy away from it. It is come a long way. I was one of the original pilot core surgical trainees back in 2007 when ISCP was launched. It wasn't the greatest launch because we didn't know what was going on, neither did our trainers. But now, 14 years later, it has evolved into a really quite good platform. And also, you know, trainers, consultants, TPDs all understand it a lot better. And don't forget that there is the ISCP help desk should you have any problems or questions with it. The main points of view from a training program director is making sure that your placements have been validated, get your global objectives signed off, because your global objectives give you the roadmap of what your expectations are going to be in order that you can get through your ARCPs first time, and there's no misunderstanding as to what is required to complete core surgical training. As you know, there'll be learning agreements, and one of the bigger changes with the new curriculum is the multi-consultant report. So get all of that set up with your educational clinical supervisors, and you will get different consultant viewpoints. Obviously, you've got the new global, generic professional capabilities and the SIPs, and there is a move away from WBAs apart from index procedures and critical conditions. And you're being assessed now in the new curriculum as per a day one consultant. And there's the potential in the new curriculum to potentially CCT earlier. But that's I suppose less relevant for core surgical training at present. Next slide, please. So this is about portfolio building and showcasing everything that you do and evidencing everything you do. And this is a list of things that you can put into your portfolio. It is not an exhaustive list. And different deaneries and schools of surgery may have different things that they want you to evidence in your portfolio. But it is really important that you evidence your portfolio in real time, save you doing it all at the last minute, and it shows that progression through surgical training. The main bits there are, you know, as surgeons, logbooks are key. There is an app that you can download, but please make sure that you link your logbook to ISCP and do your logbook in real time, because there's nothing worse than at the end of your however many 4 months or 6 months or a year at a hospital where you're trying to look back through theatre logbooks to work out which operations you were in, and it's a very time-consuming procedure. It takes 2 minutes at the end of your operating list just to log the cases that you've been in. There is this move away from workplace-based assessments in terms of having to get 40, 50, 60 in a year, but there will be some around critical conditions and index procedures. And then everything else there is pretty much showing you the breadth of what you need to evidence. And this aligns to not only the curriculum, but it aligns to the things that you're going to need to demonstrate on your ST3 application as well. Next slide, please. So courses. Normally we'd say that the sort of core courses that we want you to do are the basic surgical skills, ATLS, CRISP, and often if there's regional teaching within your region, then normally your training program directors would expect you to do a proportion or attend a proportion of those courses. We know at the college that there are backlogs with regards to certain courses, and we are working really hard to try and get more centres online, work with our trainers and faculties to bring that about, because we know there is a backlog due to effectively COVID, where people have had courses cancelled and then rebooked. So watch this space, and it's certainly something that I'm taking on as CRISP lead to try and improve that provision. You'll also have some optional courses. So certainly within KSS, we will fund most MRCS revision courses and a list of other courses that are specialty based. And then after that, you could apply to aspirational courses within KSS. And again, but that tends to be an application that goes to the TPDs and the head of school and is effectively reliant on you having passed the MRCS and done your core courses before we tend to grant those. But each deanery will have a process for study leave and a funding guide, and you really need to find out what that is and stick to the process. The other thing with study leave is also be organised, make sure that you've booked it 6 to 8 weeks in advance, and that you've got appropriate cover for any on-calls and those kind of things. Next slide, please. So the exam. Now, not passing the MRCS is often the main reason why people don't complete or get through core surgical training. So it's something that you need to try and focus on and make sure that you do, ideally, Part A by the end of the first year and Part B before your ST3 applications. But if you can get it all done in the CT1 year, then so much the better, because it gives you a little bit more time to concentrate on the other aspects of your portfolio. I'm not going to talk much about it other than to say that please don't suffer in silence if you've been unsuccessful in the exam. Certainly within KSS, we ask our trainees to contact the training program director if you've been unsuccessful at 2 attempts, because believe it or not, you can have high functioning dyslexia and have got through your A-levels and your medical school exams. And often the professional support unit at the deanery will be able to do that dyslexia assessment quite quickly, and it gives you extra time in the exam. And we often have seen that in colleagues that have failed the exam multiple times, and you don't want to get to the sort of 5th or 6th attempt and be putting that pressure on yourself. So please don't suffer in silence. The other thing is the professional support unit will have tips and tricks on exam technique, revision. I think the key here, though, is to set aside the time to revise properly, do it once, and hopefully not do it again, is my advice with regards to exams. And study groups are really useful as well if you can find another colleague who's sitting the exam with you, so that you can have those conversations and bounce ideas off. Next slide, please. So the ARCP, which is shortened for Annual Review of Competency Progression, is really an annual review. It normally happens at the end of just before the end of your core training. We often will do an interim review halfway through, and that may be face-to-face, it may be virtual on Teams, or it may be in absentia, where we as TPDs will look at your portfolio, look at your learning agreements, and just make sure that you're on track, and check that there aren't any problems. Having said that, please don't wait for your ARCP to flag a problem to your TPD. There are plenty of mechanisms of support, but what we don't want to do is ideally find out at your ARCP that there's been a problem all year, which is certainly why in KSS we do face-to-face interim reviews, in the hope that we can pick up any issues. And this is about us giving you feedback and you giving us feedback about how the training's going, what the placement's like. But for your ARCP, you do need to be organised and you do need to plan in advance. And we as consultants know when ARCPs are coming up, because we tend to get a flood of workplace-based assessments to sign off. If your consultant's on leave and you need to sign off the learning agreement, then it gets a little bit difficult to have all of that in place. Multi-source feedbacks take time because you've got to get 10 people to comment on you. So these are all things that need a bit of planning. And that's an engagement with ISCP. So it's really key that you think about your ARCPs in advance, and get that evidence uploaded onto your portfolio. And the thing about your portfolio is that whilst it may, ISCP finishes once you've CCT'd, there's something called appraisal that comes after that, which is a yearly consultant document that you have to fill in to show exactly the same thing. So it's going to be with you forever. So the sooner you get used to evidencing it, the easier the whole process will become. Don't forget your Form R, which is a declaration form about how much, the placement you've been in, whether you've been following GMC guidance, and that there aren't any SIs or investigations ongoing, and how much sick leave you've had during your placement. And the outcomes that you're aiming for will be an outcome 1 at the end of CT1, which is making progress at the required rate, and outcome 6 at the end of CT2, which means that you've completed the program. I'll leave you to look up the other outcomes. They are less favourable and you want to avoid them. Next slide, please. So as I said, there's a School of Surgery structure. Now, the training program directors sit under the head of school, okay? And we're there to support you with any training issues you have, but you don't necessarily need to come straight to us with any issues. Within your trust, you've got surgical college tutors who are in charge of the surgical training. You've got your educational clinical supervisors, and you'll also have a director of medical education in your trust. So there are other sources of help should you be running into any problems or have any training issues. Alongside that, you'll have your medical education manager and staff in your trust, and also deaneries have a medical workforce team dedicated often to core surgery who can field any questions or queries. But we're very happy as training program directors to have you communicate with us regularly about anything that's concerning you. But there are other sources of help available to you. Next slide, please. So as I mentioned, there are other sources of support. You've got your fellow trainees who've been through it before. You're as you're going to hear from Katie, who's been through core surgical training. She's a higher surgical trainee, but she's been through it. So she's a great source of experience and expertise. You've got your supervisors, you've got your training program directors. A lot of deaneries will have a professional support unit which can help with, as I mentioned, things like dyslexia assessment, tips, tricks, exam techniques, and alongside that, a practitioner health unit. So if there are any concerns, then they can always be contacted. You've also got the BMA and their wellbeing service, and the RCS has a confidential service as well, which is available 24 hours a day. So there's plenty of sources of support to get you through core surgical training. Next slide, please. So going forward, please look for all the training opportunities. I'm going to steal a phrase off of a colleague called Lisa Hadford Law, which is squeeze the juice. Look at every patient encounter as a potential for learning, assessment, and something that you can reflect on in your portfolio. So really look for those opportunities, and I'm sure Katie will talk more about how you do that. Organisation and communication. When I say that, it's effectively about being professional. A lot of training is about organising and evidencing what you're doing and communicating with the relevant people in a timely way. Be a good colleague. Often it's thought that as surgical trainees, have quite sharp elbows and push everybody out of the way so you can get to do that operation. But also being kind and considerate may get you further in terms of what people might do for you. I spend a lot of time talking to my children about how actually being nice to their teachers probably means that they'll get a bit more out of them, and it's similar in all walks of life, that actually if you're nice to people, they're probably likely to do more for you, regardless of the fact that your consultants are professionals and they will train you going forward. And the last thing to say is your training, so please take responsibility for it. You're all adult learners, and you're all equipped with the skills to make your core surgical training a fantastic experience. If there are some bumps along the way, then we are here to support you. Next slide, please. Thank you. I think we'll take questions at the end. I'll hand over to Katie.
Yeah. Oh, thank you, Ian. That's fantastic. Katie, we will probably we'll do the questions at the end because we can all answer as we feel appropriate. They're beginning to come through now. So if you've got a burning question from Ian's presentation, then please do send them through and we'll address them later on. Now, Katie, one of our fantastic core surgical trainees from Peninsula, who's been a pleasure to work with over the last couple of years. I'm absolutely delighted to welcome her to give her perspective on core surgical training and the ups and downs, ins and outs, and how you can make the best of the next 2 years. Thanks, Katie.
Thanks, Ms. McClarty, and thank you very much also to the college for having me tonight. It's a real pleasure to come and present today. Next slide, please. So first off, everybody, I just want to extend my huge congratulations to each and every one of you for achieving a core surgical number. It's getting more difficult as the years go on. I don't sadly have the 2021 competition ratios, but as you can see below, the application rate and the competition ratio was 3.84 2 years ago. So you really have to give yourself a pat on the back, but the momentum definitely doesn't stop here. Next slide, please. So just a bit about myself, just to kind of give you my brief run of where I ended up and how I ended up where I am today. I finished my FY2 up in Scotland and then secured a core surgical number in the southwest. I didn't know anybody, I didn't know a lot about the area, but ultimately I had the best time both in and outside of work. And I think through enjoyment of both in and out of work, I was able to get the most out of both worlds and then secure my top choice of ST3 deanery, and I'm now back up in the homeland as an ST3 in general surgery. My talk today will kind of focus on different elements of the training and how to get the most out of it and get to where you want to be. Next slide, please. So, as I said previously, time will go very, very quickly. You've got 2 years of different specialties, different departments, and for some of you, actually a lot of you, you'll probably be in different hospitals. So it's really important to kind of integrate yourself into a team straight away and throw yourself into opportunities to get the most out of what you want to get and where you want to be in the future. Also as well, you may be going into core surgical training with an interest in 2 different specialties and not knowing really where you want to be. This is the ideal opportunity to get the most out of each opportunity, both in theatre, in clinic, on call, to find out the kind of nitty-gritty bits of the job, to find out if that's where you want to see yourself going, to end up in ST3 and going forward to consultancy. Next slide, please. So as I said previously, ICP is your best friend. It still is my best friend. It'll probably be my best friend for the next 6 years as I get through my training. Get to grips with it early. I hope that you've all logged on already and sought out kind of each bit of the portfolio as to where to kind of add assessments into it, add your supervisors into your training schedule, and set up your plan and learning agreements. Be aware of your global objectives and hit the ground running, and ensure you've got time as you go through to kind of gain all those assessments and index procedures as you go through. Getting assessments done early was what got me through my training with no real bumps in the road from this perspective. Every case in theatre, you can send 3 to 4 assessments to your supervisor and discuss as you're going through if it's okay to send them those assessments. I also think it's important to discuss the case both before and after to ensure that you've got the most out of it. And again, you can send a CBT or a KEX with regards to what you've seen in theatre. And again, that also extends to both the on-call and elective setting if you're on the ward round. Log everything, both inside and outside of the operating theatre. The more evidence you have, the more backing you have as to how hard you've worked through the year, and also the kind of progression of where you've come to, going from a kind of novice within the field to then gaining experience with operative procedures. And finding that your clinical experience and management of patients will also take an exponential curve with regards to how you progress. Next slide, please. Next slide. Oh, sorry. So exams, dreaded exams. I could speak all day about my journey with exams, but essentially it's not a plain sailing journey. Mine certainly wasn't. I really struggled with my Part A exam. But if you are having trouble, as was said previously, do not panic. There are people that you can speak to. I've generally pulled on support mechanisms from colleagues around me, seniors above me, and then of course my supervisors, and I was directed in the realms of the support services, and they can really help with trying to get your the way that you study at the moment and try and tweak it to be the one that's going to optimize your outcome with regards to the exam. And with regards to Part B on DONS, definitely find a friend and study together. Make the time after work, weekends, days off, any time. Really focus on your exams, because like we said previously, that's what's going to be the hurdles of you getting out of core surgical training and into the ST3 world. Practice and practice and practice some more, and ultimately I found clinics really helpful for specialties that I wasn't quite familiar with. Part B, you're thrown into vascular scenarios, plastic scenarios, orthopedic scenarios, and I didn't have jobs in these specialties. I made the time and went to clinics, and through that as well you can also gain assessments and gain feedback and reflect on what you've learned, and that all helps towards gaining a successful outcome when it comes to your exam. Next slide, please. So courses, it's been mentioned the mandatory courses that we've got to get through your training. The bottleneck's been mentioned already, and it's thrown a real spanner in the works. At the moment there's waiting lists, postponed dates and bottlenecks, and trying to find certain courses can be a real needle in a haystack at the moment. But if you seek the mandatory courses early and be organised, and sometimes they're not on the RCS website yet if your local centre run a course. In Peninsula we had a coordinator for postgraduate courses. Make sure you make yourself known to that person and get your name on a waiting list, and you should be able to book in to the course as soon as you get a space. In terms of making sure that you have all these for ST3 is really important. At the moment there's a grace period, of course, but I think as soon as you get organised and get involved in these things, it'll be, for your portfolio wise going forward, it's a tick box that it can be easily achieved. Next slide, please. So theatre is probably what we're all, which is our favourite part of the job. Definitely my favourite part of the job. There are opportunities everywhere in theatre. There's CPOD, there's elective, and certain specialties are actually running statutory lists at the moment. If someone asks you to come in and assist, always try and go. You'll always gain something from cases. Seek opportunity. If you're not rotated for anything that day, if you finish the ward round and you're at a bit of a loose end, go down to theatres, find a theatre. You might need an extra hand. Is there a registrar that's going to do an appendix soon that they might need someone to come and assist them? And you never know, you may well come out with a bit more than you bargained for that day. Always prep as much as you can prior to the list, knowing the patient, knowing the indication, knowing the procedure, will all aid in both your anatomy knowledge, your clinical management knowledge, but also it just shows that you're actually very interested, and if you're asked questions throughout the list, will show that you've actually made the effort to prepare. And ultimately your trainer, I think, will then take on board that you've made an effort, and you may well get a lot more out of it as you go through your training. I don't suggest that you keep lists of theatre patient lists and logs. Always log it on the same day. It just keeps everything organised, and it takes 2 seconds if you're even writing the op note for an appendix you did. It takes just as much time just to log the case in your logbook. The more you go to theatre, the more you'll experience, the more knowledge you'll gain, the more you'll be familiar with the anatomy, the more you'll get to do. Highlight yourself to registrars. That was the top tip, I think. I definitely kind of highlighted myself to registrars that I was keen and able, and if I had a spare minute, if they were willing to take me to theatre, I would definitely jump on and go with them. And also, if they're at a loose end, they're more likely to come to you if you've highlighted yourself previously. And like I say, always go if you've got the opportunity and there's no other commitments. Next slide, please. Clinic, I think it's a daunting place for a core surgical trainee. FY doctors don't really tend to get to experience clinic in the previous time you've experienced this as a medical student sat in the corner taking notes. But clinic is such a goldmine of opportunity and wealth of knowledge with regards to clinical signs, clinical management, and actually getting to grips with making a management plan and decisions with regards to patient care. It's also very good in getting to grips with dictation, which again can be very daunting, but it's part and parcel of what you have to do as you go up the ladder to get to registrar level, where you're going to be doing clinics by yourself, and then getting up to consultant, where you're going to be doing them as your bread and butter. As I previously mentioned, these are great MRCS practice, getting to grips with Dopplers, getting to grips with flexi-guided catheters and things that you might also have to do on a night shift as an ST3 in general surgery. It's quite good experience to have all this kind of foundation knowledge before you have to experience that on a night shift when you're at a loose end. Next slide, please. But most of all, have fun. This is an extremely exciting time. Also, it can be a really demanding and stressful time. Core surgical training is extremely busy. You've got a lot to fit in the 2 years or 18 months before your ST3 application. Burnout, stress, and anxiety are all issues that will face either one of us or your friends and colleagues. Like I say, there's support networks around. Tag on to that if you're having a hard time, because we all experience it at some point. And take time for yourself outside of work, and do whatever makes you happy outside of work, and take time to relax. But as I say, if you follow these top tips and just throw yourself into opportunity, be organised and enjoy it, I think you'll come out shining on the other side. Thank you. That's me.
Great, Katie, thank you very much. We've got some questions coming through, which I will pose to Ian and Katie, if that's okay, and I may even answer some of them a little bit myself. But to start with, if you did basic surgical skills or ATLS in F1 and F2, are you expected to do it again as a mandatory course for CST, please? Katie.
BSS, no. ATLS, you've got to revalidate it every 3 years. So if it comes within that time, 4 years, I think it is, you've got to revalidate it. So keep an eye on when your revalidation date is.
Mm-hmm. And Ian, while filling the e-logbook, is it compulsory to fill in the operation notes too?
No, but it's quite a good idea to, if you can, jot something in the operation note bit of the logbook to maybe tell you something about the case, something you've learned, something that was particularly difficult about it. I put gallbladder. I still use my e-logbook, and when I put gallbladders in, I grade them, and it's how I get an idea of how difficult the operation was.
And of course, if you do write an operation note, you can then discuss it with your consultant and get a CEX or out of it as well. You know, writing a good operation note that stands up in court is a particular skill that we all have to learn. So take the opportunities everywhere, just as Katie has suggested. Now, what do you do if you don't have much exposure to your chosen future specialty during core surgical training? Ian.
It depends on your deanery. So some of our core surgical training posts are themed, and some are unlinked. So if you know, and sometimes you come into core surgical training with an idea of what you want to do, and then you change your mind. So what we tend to say to people that are in themed jobs is, if you'd like to, you can actually give up that theme job at the end of CT1 and go into a pool where you can potentially choose another job that will potentially give you exposure to whatever the new interest is, or the new specialty that interests you is.
And this is one for either of you, really. Is there a maximum study budget for CT1? I was told by my TPD that we have a maximum of 600, but online it says it is unlimited as per HEE. Katie, tell us the reality, and then Ian can tell us the rules.
So initially, when I started, it was unlimited, but they introduced a cap of 400 in Peninsula when I got to the end. I think it's dependent on the funding and of your deanery.
Ian.
I suspect it may differ. Certainly within KSS, we would fund all of your mandatory courses, and we have a list of you know, MRCS exam courses and other specialty courses that we would fund. Obviously, with anything, it's difficult for it to be unlimited, and that's why we've put in, you know, an aspirational course funding form, which we do limit to courses that are relevant to core surgical training. We're not going to be paying for you to pop to the Bahamas to a conference that you're not even presenting at, unfortunately.
And often we'll pay for UK courses, but we won't pay for travel or accommodation when people go and do things abroad as well. But it is somewhat deanery dependent. Okay. For those of us in unlinked posts, i.e. London, how is it decided our tracks for CT2? Now, Ian may not be able to answer that one, and I may not be able to answer that one. That may be one for your London TPD. Ian, can you answer that one?
I don't know what the process is in London. Certainly in KSS, we have a scoring system based on your portfolio, and we rank you at the end of CT1, and those that are doing well will get the preferential post at CT2. Although this does cause people worry about this, and normally certainly in KSS there are enough posts to go around in terms of people to get the specialty that they want. But having said that, if you really want a particularly popular post, such as, you know, a plastics post or something where there may not be many jobs, then you are up against your colleagues in your region, and that's how we do it in KSS, because it seems to be the most fairest way, including people that give up their posts. You know, we don't encourage, we don't allow swaps between individuals, so it's all fair and transparent.
Okay. So I think probably again for Ian this one, if you observed operations abroad in another country, can they included in your e-logbook? Just disappeared off my screen. Can they be included in your e-logbook, although some information cannot be validated, e.g. the consultant or hospital?
Now, I think they can be included in your e-log, but the difficulty is validating them. Certainly, I did a lot of portfolio stations for core surgical training interviews, and there were logbooks from abroad, and they were signed, but they weren't necessarily validated with a GMC number or a stamp or something that can authorize them as valid logbooks. And that, I think there's nothing wrong with logging them, but you do need to make sure that you've either got a signed bit of paper with a stamp and an equivalent of a GMC or registration number to validate them.
Okay. Katie, one for you here, if that's okay. I think this is somebody who's not yet a core surgical trainee, but hoping to be in plastic surgery. And they say they're interested in applying for CST this year with a keen interest in plastic surgery. I would really appreciate if the panel would be able to give some highlights, the tips on boosting portfolio according to the self-assessment guide, and how to get into competitive training in plastic surgery themed posts. Well, I'll start by saying that core national selection, you rank your posts that you want to do. So if you want to have plastic surgical post, then you need to be high enough up in the rankings when you go through your interview process that you get to have the post that you want. And that's pretty much the same for every specialty. So it is looking at the person's specification for CST, not necessarily plastics, and making sure that you are the most competitive person for CST in the country and well prepared for your interview. Katie, would you like to add anything to that?
Yeah, it's the person's specification and making sure you've got adequate evidence. The evidence is going to be key with regards to verification of that to ensure that you get maximum points. And practice interview, always practice interview.
Ian, anything to add to that?
I think the key with applications and is looking at the application form in advance and making sure that you've got all the gaps covered. So you're not strong just in one area, but you're scoring the maximum across all domains of an application form, because there's only a certain amount of marks you can get for audit. But if you've got nothing in research, nothing in teaching, you're going to score 0. And if you wait till the application's open to work out where your gaps are, you're not going to have time to rectify the problem. And that's where you need to start looking at the application now and tailoring what you do to fill those gaps is my top tip.
Thank you. And another one for Ian. If you're moving between hospitals, should you apply for funding for courses from the hospital you are at when you book the course, or the one where you are attending the course?
So I suppose there's nothing wrong with applying for funding at the hospital when you book the course, but you will need to apply for the study leave from the hospital that you're going to. Now, it's probably worth clarifying that with the hospital you're going to as well, because although the money's coming from the deanery, it's how it's charged, because often you might pay for the course, and then once you've got a receipt, then you're going to be applying often to the trust that you're at for reimbursement. So actually, having said that, I think you probably need to apply to the trust that you were going to as well, because it might cause a bit of a problem, because the money won't be coming from the previous trust. And that's where it comes down to organisation and communication. You need to speak to your trust early and make sure that you can have the time off for these courses, and don't leave it to the first day you arrive.
Okay. Here's one for Katie. Hi Katie, could you kindly share any tips for MRCS Part A? Mine is coming up and my MCQ average is still very low. Any last minute tips or tips for next time, as I may have to resit it? I would be really appreciated.
So when I first started out, everyone's advice was questions, 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 questions. And to be honest, that really didn't get me anywhere. I changed my learning style, and actually I started to learn the nitty-gritty bits of the anatomy, the physiology, and I sat down and learned those things and then went back and did questions. So I find out where your gaps in knowledge are, and go back and actually re-revise the kind of basic science of those elements, and then re-tackle questions. I would use different resources. I changed question banks. I also spoke to a lot of people who'd had kind of past questions and things like that, and just gain as much different perspective if your current study pattern isn't working so well. But definitely gaps in knowledge, and then re-revise the core elements to then tackle the questions with a good foundation going into those, would be my advice.
Okay. And here is a tricky one for Ian, I'm afraid. Can one apply again for CST during CST1 to try and get a run-through post? Would that be actively discouraged?
Yeah, I saw that question and thought it's a bit of a tricky one. I suppose you probably can, but I would have thought it would be actively discouraged. And the further you move away from your foundation years, you're less likely to potentially get a run-through post. But I would concentrate more on your core surgical training post and just getting straight into a number, rather than trying to reapply, because that's going to distract you from the task at hand.
And most run-through specialties have ST3 entry, so you would be more looked at against the people going to ST3, which may disadvantage you. So completing your program is probably a much better option unless you want a complete change of specialty. Right. Given the changes to the new curriculum in relation to outcome-based progression, if a core surgical trainee, in brackets, e.g. through experience gained prior or during CT1, has both parts of MRCS, the mandatory courses, workplace assessments and competencies, numbers, and are in a position to apply for ST3 position in CT1, would this application be discussed with the TPD or deanery if evidenced in portfolio? Right, Ian, that was for you, but if you wish, I could answer that for you.
So it would be highly unlikely that you could get all of that before the end of CT1. We have looked at it for OMFS trainees who may have a lot of the core competencies coming into core surgical training, where we may be able to reduce their training, particularly if they're run through, and they could start earlier on the higher OMFS training program. But I think it would be a real challenge to be competitive after a year to go into ST3 applications. And I guess that would be something that you'd have to discuss with your TPD and deanery as to whether they'd support you, because everybody's different. The outcome-based progression is more aimed at higher surgical training, because over the 6 years you've got a little bit more time to potentially finish a bit early. But I would have thought most people still probably won't finish more than 6 months early at best. So yeah, that's.
Yeah. It would need be the thing with surgical training is that your ARCP looks at the year that you have just completed, not that everything that you have done in the past. Although that is looked at CCT, it's not looked at during ARCPs. It will purely be a year of training. If you were so far forward in your career, it's unlikely actually that you would have got a CT1 post, because you would probably have pushed yourself out of competition by having too much experience prior to CT1, and would have been advised to apply for ST3 straight away. Ian is completely right about OMFS. OMFS trainees only have to satisfactorily complete CT1 and have a form of good standing to enter ST3 application. And they don't have to do CT2 as long as they've got the relevant competencies required. Right. Is there any advice the panel might have for those who've needed time out of training, e.g. FY3 years, with respect to the upcoming bottleneck at ST3 and being penalised at ST3 for having worked extra years in a surgical position? Ian.
I think my answer to that is that whatever you do that is a bit of time out of training or an FY3 year is it going to add value to your application? Because if you're taking some time out, you are going to need to be that bit more competitive when it comes to the application, because you're going to be at a slight disadvantage because you're a bit further away from graduation. So your application just has to be stronger. So that's my advice, is that, you know, if you're not successful in you know, at the bottleneck from foundation year into core and vice versa, and same way into core into higher, then whatever you do as time out, you try and build that portfolio so that you are stronger as a result, so that you almost compensate for the fact you've taken the extra year.
Thank you. Right, one for Katie that Ian may want to chip in afterwards. But Katie, if your head of service had pressurised the registrars not to let SHOs, including core surgical trainees, participate in trauma lists, how would you have combated it, and how to get yourself into theatre?
That one, I would definitely have highlighted it to my educational supervisor. If you're having roadblocks about getting into theatre because of a registrar, I don't think that's appropriate. I would definitely escalate to your educational supervisor at that stage. You know, theatre is mandatory to get your index procedures and actually gain experience to where you want to get to be in life. And roadblocks, I don't know what the reasoning for the roadblock would be, but it might be good to kind of explore why the roadblock's there in the first place. But ultimately, you're going to have to escalate to your supervisor to kind of highlight the issue and find out from your colleagues if they are having the same issue as you, to kind of find out if it's a personal issue or if it's a department issue, and tackle it that way, I think.
I mean, there's often seen as a conflict between service and training, which isn't there in particularly. And if you found that your educational supervisor was unable to help, then you could also go through your college tutor, director of medical education, or TPD, and most TPDs would be very happy to help and would want to know about a situation where a manager or a head of service was trying to stop training, or not stop training, but avoid trainees going into theatre. Trauma training is an intrinsic part of CST training in orthopaedics, and therefore it has to be facilitated. But you don't need to go into battle yourself. You can talk it through with your AES or college tutor in the first instance if you have one. Right. Apparently the follow-up question to that is the reason provided is due to risk of complications, being told consultants don't want to take ownership for this. Sounds like a little bit of communication is required there, doesn't it, between consultants and educators? Okay. Right. One more. Is there any advice the panel might have for those who have needed time out of training, e.g. FY3 years, with respect to the upcoming bottleneck at ST3? Oh no, I've done that one. I do apologise, and that's not the one I wanted. The one I wanted was, I'll paraphrase it because I haven't got it in front of me. If you've come straight through training and you complete CST, is it reasonable to take a year or two out before going into ST3 training? Ian?
I think it depends what you want to do. I think it depends what you want to do with that. So I have friends that went to New Zealand after their core surgical training and did transplants and urology, but have been unsuccessful in obtaining a training number. So I would bear in mind that even at ST3 you are penalised, well, not penalised, but it's taken into account how many years you've taken, and your score is divided on different aspects of self-assessment. So I think if your application is competitive enough and your year out or 2 years out will benefit your application, i.e. gain you more points for the higher degree, or you'll gain publications out of it, and then so be it. But I would just be careful with what you want to get out of those years.
Ian,
Yeah, I would say the same. It comes back to what I said before. Any time out is about value added. If it's going to add value to your application and you can justify it, then I think it's reasonable. But as cases allude to, you are going to be a bit more disadvantaged because of that extra time, and that's where it has to add the value.
Okay. So Katie, I'm going to ask you a question. You've gone for remote and rural surgery, haven't you, as a theme of your general surgery? Can I ask you what it was about general surgery that got you hooked? Why did you, through your core trainings, I know you battled, I tried to convince you to be a urologist and see the light. What was it that really inspired you to go into your ST3 in remote and rural general surgery?
It's for me, definitely it's the breadth of knowledge and breadth of procedure that you get to do as a remote and rural surgeon, and plus the locations are beautiful. You can be dealing with anything from a Cat 1 C-section to an appendix to putting a shoulder back in to having to burr hole someone who's got a subdural on Shetland who can't get off the island. So I just think the sheer breadth, and I really enjoy emergency operating. The sheer excitement of not knowing what's going to come in through the door and having to pull on a whole host of different skills. So I gained a lot through urology, I gained a lot in general surgery, and I like having to pull on different aspects of things I've learned, definitely.
Thank you. And Ian, just one for you. Why did you want to be training program director for core surgery? What do you get out of it?
So maybe it sounds a bit cliche, but it is about training the future generation. I look back at the people that trained me and how they inspired me to be, the consultant I am today, and what they've taught me. And I see it as a huge privilege to train the future generation. And it's not for all of us, but I love training. And it's the ability to do an operation well is great, but the ability to train somebody to do that operation as well as you is what I aspire to. And there are just so many aspects to it, and it's great to see people coming through the program and becoming your consultant colleagues in the future. And that's how I view all of my core surgical trainees and my higher surgical trainees, potential colleagues of the future. And it's almost like a bit of a job interview when you come and work for us. We're assessing whether actually I'd quite like Katie or to come back and work with us, and how can we make that happen.
Fantastic, thank you. Well, I'm going to bring this evening to a close. I do hope those of you listening in have found this interesting and informative. We all really hope that you enjoy your 2 years of surgical training, that you come out of it as enthused as Katie and Ian are, and you succeed in every way. Some people have bumps along the road, some people take a little bit longer. It really doesn't matter. Look after yourselves, look after one another, and enjoy the next 2 years. Best of luck to you all. Good night.